Dear ladies and gentlemen, greetings from the Malaysian Obstetric Medicine Society, and I'm privileged to meet all of you all here today in our another webinar titled Hepatitis B in Pregnancy and Update. Ladies and gentlemen, I've got no conflict of interest in this talk. In the next 25 minutes, ladies and gentlemen, I would like to highlight 4 points. The importance of universal screening of hepatitis B in pregnancy, the safety of hepatitis B vaccination. It is actually not contraindicated. The importance of monitoring hepatitis B viral loads among positive patients, and the safety and benefits of Tenofovir in pregnancy. So ladies and gentlemen, I would like to remind everyone one key fact. Among the many Southeast Asian countries throughout the world, Malaysia is one of them who have actually achieved global elimination of 3 diseases. Malaysia has achieved elimination of HIV. Malaysia has eliminated mother-to-child transmission of hepatitis B. And similarly, Malaysia has eliminated syphilis. And this is based on the WHO report in 2018. So what does elimination mean? With regards to hepatitis B, our target, our aim, and what we have achieved is we have reduced the incidence of mother-to-child transmission to below 0.1%. Yes, ladies and gentlemen, below 0.1%. So I believe this talk is timely. Why? Because in the last 5 years, there's been significant updates with regards to how we manage hepatitis B in pregnancy. First was the WHO Global Health Sector Strategy, which came out about viral hepatitis, a general guideline between 2016 and 2021. And finally, an updated guidelines from WHO that came out in July 2020, talking about antiviral prophylaxis in pregnancy and hepatitis B in pregnancy. And hence, I'm going to do a quick update about hepatitis B in pregnancy. So ladies and gentlemen, let's take a look on where we sit. And this is the global map for hepatitis B mortality. Now, you don't live in a country where there's highly high mortality rate, but we do live in a region where the mortality rate from hepatitis B remains moderately high. Let's take a look at Malaysia and its neighboring countries. In the region, ladies and gentlemen, the mortality from hepatitis B is about 22.5 to 33.49 per 100,000. So ladies and gentlemen, hepatitis B remains a significant infection in these parts of the world. Next, let's take a look at trends. Let's keep COVID at the back of our mind for the next few seconds. And let's take a look at 4 conditions. HIV, the global trend of HIV peaked at 2005. It is reducing in trend. Malaria. Now the trend of malaria is also downwards trend. Let's take a look at tuberculosis. Although drug-resistant tuberculosis is on the rise, generally TB is on the reduction trend as well. But unfortunately, ladies and gentlemen, hepatitis B is on the rise. Hence, it's important to update the guidelines. It's important to review and reflect the way we manage hepatitis B, especially in pregnancy, because the incidence is on the rise, because we live in a highly endemic area. Mortality from hepatitis B remains high. So ladies and gentlemen, what is already known? The general incidence of hepatitis B in our population is between 0.3 to 8%. Now, the commonest mode of transmission is vertical transmission, where almost 60 to 90% of hepatitis B occurs via the vertical route. Now, the risk of transmission is highest if the mother has either got an hepatitis B E antigen positive, or if the mother has got a high hepatitis B viral load. Now, ladies and gentlemen, a high viral load is identified and defined as a viral load of beyond 200,000 copies per mil, or a log of beyond 5.3. So although we use the concept of U equals U for HIV, in hepatitis B, the number to remember is 200,000. We also know, ladies and gentlemen, that active and passive immunoprophylaxis reduces the vertical transmission by 90%, not 100%. So if you currently have a policy where you provide all hepatitis B mothers with active and passive immunoprophylaxis, you may be correct 90% of the time. You may be wrong 10% of the time. So ladies and gentlemen, we need to progress something from our current practice. Our aim is to eliminate, to reduce up to 0.1%. So the 10% that you miss is still inefficient, inadequate. And we also know that antiviral therapy in the third trimester further reduces the transmission risk from the mother to the baby, especially with mothers with a high viral load of hepatitis B. So ladies and gentlemen, active and passive immunoprophylaxis blindly to everyone is not enough. You need to check viral loads. Those with high viral loads, you need to give antiretroviral. So what are the other facts about hepatitis B, ladies and gentlemen? If the mother is hepatitis B surface antigen positive, if the mother is hepatitis B E antigen negative, the risk of transmission is 25%. However, if the mother is hepatitis B surface antigen and E antigen positive, the risk of transmission is higher at about 90%. So the moment you have confirmed her surface antigen, the next two steps that you do is to confirm her E antigen and a viral load. And we do know that 90% of these infected infants will later become chronic hepatitis B carriers. So ladies and gentlemen, our aim is to prevent chronic infections. Our aim is to prevent vertical transmissions. And 25% of these chronic carriers may later die from cirrhosis or primary hepatocellular carcinoma, which could have been prevented. And sometimes acute hepatitis and fulminant hepatitis are not uncommon in the neonates. So ladies and gentlemen, with that, almost major guidelines throughout the world recommend universal screening for hepatitis B in pregnancy. The WHO recommends universal screening, the NICE guidelines, the RANSCOG guidelines, the ACOG guidelines, and the CDC guidelines. We do know that it is advocated to universally screen all mothers for hepatitis B in pregnancy, but unfortunately in Malaysia, in most instances, we still selectively screen. So ladies and gentlemen, I hope we can change our practice from today. Universally screening for COVID alone is not enough. We should universally screen every single pregnant mother at booking for hepatitis B because it is highly preventable. The risk of vertical transmission can be eliminated. You can actually prevent infants living with chronic hepatitis B. In fact, a progression towards hepatitis B, many countries now advocate universal screening of hepatitis C. Now, it is not recommended by NICE guidelines yet, but American College, the CDC, and even the RANSCOG now recommend, apart from screening for hepatitis B, you should also screen for hepatitis C in pregnancy. Now, why is that so, ladies and gentlemen? I'm sure everyone living in Malaysia, and we have followed up with recent trends in Malaysia in the last 4 years, you can now know that hepatitis C can be treated, can be eliminated, and that remains the goal by our Director General of Health. Yes, ladies and gentlemen, if you identify people with hepatitis C, you can actually treat and cure them, and treatment and cure is available. And what other better time to screen than in pregnancy? So ladies and gentlemen, apart from screening for COVID, apart from screening for hepatitis B, apart from screening for VDRL, I believe we should also screen for B and C. B is to prevent a maternal and child infection. C is to treat the mother postpartum, and you can actually cure her. Well, let's talk about hepatitis B vaccination. We spoke about COVID vaccination. We do know that COVID vaccination is safe. Similarly, ladies and gentlemen, hepatitis B is not a live vaccine. You can actually vaccinate someone with hepatitis B in pregnancy. It is not contraindicated. So most of the time, although we do had some reservations about hepatitis B vaccination, it is not a live virus. You can vaccinate someone in the pre-pregnancy state. You can vaccinate someone in the antenatal state or even in the postpartum state. So it's important to screen. If they are negative, vaccinate. You can actually screen. If if their antibodies are low, you can also provide vaccination in the pregnancy or puerperal state. So that later brings on to our next topic, which is antenatal management of patients with hepatitis B. So ladies and gentlemen, what has been our standard practice? Our standard practice is to selectively screen. And the moment you find the mother to be positive, you will usually provide 0.5 mils of hepatitis B immunoglobulin to the infant who had mothers who have got confirmed to be hepatitis B soon after delivery. And this has to be repeated at 3 months and 6 months. But ladies and gentlemen, the efficacy of this is only 75% if you give immunoglobulin alone to all babies whose mothers were hepatitis B positive. Another standard practice in Malaysia, apart from immunoglobulin, we add a hepatitis B vaccination as per routine. And a combination of immunoglobulin and vaccination reduces the efficacy to 90%. However, ladies and gentlemen, 10% of the time you may still miss a vertical transmission. So the third agent, apart from immunoglobulin, apart from vaccination, is to screen the mothers who have got E antigen positive, screen mothers with high viral load and suppress the viral load with Tenofovir. And that is the third option to eliminate hepatitis B vertical transmission. So what are the predictors of perinatal transmission? The perinatal transmission is highest during labor and delivery. Viral load from the mother is the most essential predictor. As mentioned earlier, hepatitis B E antigen is the second most important predictor of vertical transmission. The mother is E antibody positive. The risk of transmission can be as high as 90%. The mother's E antibody negative. The risk of transmission is low. So ladies and gentlemen, there have been various papers in the last few years looking into the incidence of hepatitis B in pregnancy and the virology predictors and the incidence of flare. Although flare is uncommon during pregnancy, it is possible, especially in the postpartum period. Now, ladies and gentlemen, if you were to routinely perform a liver function test, it can be highly abnormal in the immediate postpartum period. But please remember, for all your hepatitis B patients, the risk of having a flare in pregnancy is highest in the postpartum period. And this is the only period where the mother who have got good intensified care in the antenatal period is often neglected and seen 6 weeks later. And she's often lost between the obstetric unit and the gastroenterology unit. So please remember, all your hepatitis B patients, you should be having surveillance, you should be monitoring the liver function test, especially between 3 to 6 weeks postpartum, because the incidence of flare is highest in the postpartum period. So what did the WHO paper in 2017 recommend, ladies and gentlemen? It recommends that for infants born to hepatitis B mothers, they should receive the hepatitis B vaccine, and the delivery vaccine should be within 24 hours. And that should be a key performance indicator. And that should be followed by 2 or 3 doses of hepatitis B vaccination. What does the consolidated guidelines in 2019 mention? That all pregnant mothers should be universally screened for hepatitis B surface antigen at booking. Now, this is one practice in Malaysia that I believe we should strongly follow and adhere to. And hopefully we can change our practice, ladies and gentlemen, because hepatitis B is highly prevalent. We should universally screen every single pregnant mother in every pregnancy. Now, what are the new recommendations, ladies and gentlemen, based on the WHO guidelines? Apart from universal screening, apart from universal vaccination, the WHO now recommends that for all patients who are hepatitis B positive, you should check the viral load at 28 weeks. There are two numbers which is significant. You can either use a level of 5.3 log of 10 and higher, or a viral load of above 200,000 international units per mil. If they've got a viral load of above 200,000, they are considered high viral load. And these patients should receive Tenofovir prophylaxis from 28 weeks onwards until birth to prevent mother-to-child transmission. So yes, ladies and gentlemen, in the past, we do not routinely check for viral loads. You will miss 10% of the population. Hence, the current recommendation is to check viral loads at 28 weeks. So let's talk about antiviral treatment. Which guidelines recommends Tenofovir? Apart from the WHO, the CDC recommends. The American College of Guidelines now recommends antiviral therapy. And similarly, RENSCOG guidelines also recommend antiviral treatment for hepatitis B in pregnancy. I hope we similarly in Malaysia can also adhere to these international guidelines about antiviral treatment in pregnancy. Apart from that, ladies and gentlemen, there's various other studies looking into management of hepatitis B in pregnancy. And apart from the risk of 10% being missed in the population, this wonderful paper also noted that in their cohort, almost 1 in 6 women had active hepatitis B, had high viral loads. So in certain parts of the world, it can be as high as 1 in 6, ladies and gentlemen. So you do need to screen, you do need to check viral loads, because you may be missing between 1 to 6 to 1 in 10 women with a high viral load. Various other papers. One paper, for example, is this position paper looking into prophylaxis, treatment, and management of hepatitis B in Australia, UK, and New Zealand. Recommend similar outcomes. You have to screen, you have to monitor, you have to treat. Now, how effective and what is the level of significance? I quoted a log of 5.3. I quoted a significance of 200,000. Now, some other papers have quoted a different range, ladies and gentlemen. An example is this paper that quoted that patients with a viral load of 17,000 and above should be watched closely, should be given Tenofovir. So I believe it's important to watch this space. Just like the concept of U equals U, how from a copy of 50 copies, we have gone down to 20 copies, we have gone down to undetectable levels. We're now looking at 200,000. But I believe with time, that level might come down further. But as of now, 200,000 seems to be the level of significance. So the new recommendations, ladies and gentlemen, screen for hepatitis B. If the hepatitis B surface antigen positive, screen for hepatitis E antigen, screen for viral loads, start Tenofovir. The aim is to eliminate hepatitis B infections. Now, what paper did you get the number of 5.3 log from? I believe it was this paper, which was a systematic review and meta-analysis published in the Lancet. They looked at the level of significance, and 5.3 log seems to be the magic number. And mothers beyond this log seem to have a higher risk of vertical transmission as compared to those below this log. Similarly, ladies and gentlemen, 200,000 seems to be the level of significance. Now, with regards to hepatitis B, we've came a long way from 1992. From where we started with interferon to lamivudine to adafovir, now we're talking about tenofovir, and that seems to be the current drug of choice, especially since 2016. But ladies and gentlemen, is tenofovir effective in reduction of viral load? I believe this paper, which was published in the New England Journal of Medicine, gives us that answer. So this was a wonderful randomized controlled trial, dividing women into 2 groups. One group was assigned to the control group, they had standard care, they had no tenofovir. Another group were randomized into a standard of care and they were given tenofovir. Now, the amount of patients in each group were almost similar, and this study showed without tenofovir, the incidence of vertical transmission remains significant. But if you were to start tenofovir for mothers with a high viral load, the risk of vertical transmission is almost nil, and hence tenofovir is highly effective. Now, similarly, this other paper looked into efficacy and safety of various antiviral prophylaxis with regards to pregnancy and childbirth. And they showed, irrespective of the gestation, irrespective of the mother's hepatitis B, E antigen status, tenofovir as compared to lamivudine and talvivudine, tenofovir was safe, was more effective, and hence it recommended tenofovir as the antiviral of choice for mothers with hepatitis B infection. So with that, ladies and gentlemen, various other papers, you just need to Google, you will find the importance of starting tenofovir, the importance of reducing maternal to child transmission of hepatitis B. So with that, I would like to conclude that intrapartum management is just as the same as per routine. The mode of delivery is not affected. It does not cause an infection of perinatal transmission. However, it is good practice to avoid invasive procedures, namely scalp internal CTG monitoring, a traumatic instrumental delivery, or a mid-cavity rotational delivery. But ladies and gentlemen, even in patients with a high viral load, you should not subject them to a cesarean section because the risk from a cesarean section far outweighs the benefits of a vaginal delivery. However, the mother with hepatitis B presents with leaking, you should manage her actively and not expectantly and wait for 24 hours later. For infants with hepatitis B, mother's breastfeeding is not contraindicated. Give them active and passive immunization. Give them hepatitis B immunoglobulin within 12 to 48 hours, and then vaccinate them. And occasionally, in preterm infants or infants with low birth weight, you should in fact give them 4 doses instead of the common 3 doses. So ladies and gentlemen, I'm going to divide the management of antenatal management into 2 groups. If a pregnant mother is already on antiviral therapy prior to the pregnancy, continue with in pregnancy. You can divide her into 2 groups. If she's got mild to moderate disease, monitor her closely every 3 months. If she's got an advanced disease, where your fibroscan shows stage 3, stage 4, this is the patient that you should be monitored in your high-risk pregnancy unit. Monitor her 1 to 2 monthly. She should actually have prophylactic OGDS to ban the portal hypertension and esophageal varices. On the other hand, the pregnant mother is not on any retroviral therapy. If she's got mild to moderate disease, monitor her with ALT, screen for hepatocellular carcinoma. Please remember the risk of flare is highest in the postnatal period. If the mother's got hepatitis B, if she's well, but a viral load is above 200,000, the recommendation is to start tenofovir. On the other hand, the mother is hepatitis B, she's got an advanced disease. You should refer her to a liver specialist. You should watch her closely. You should ban her prophylactically because she may have bleeding from esophageal varices. Similarly, ladies and gentlemen, just like any other test in pregnancy, it is affected by pregnancy, and it's important to use pregnancy-specific values. I would like to bring your attention to this wonderful paper by BMJ, which gives us a normal reference range, which differs between non-pregnant and pregnant mother, and how the ALT changes in each trimester. So the next time you're going to do a liver function test, it's important to use pregnancy-specific values. Although please remember, it is extremely difficult to interpret liver function tests in the immediate postpartum period because the ALT and the AST may be elevated. So ladies and gentlemen, similarly, the paper by WHO for hepatitis B positive mothers screen them. If they are positive, check the viral load. If they have got low viral loads, manage as per routine. If they have got high viral loads, start tenofovir, continue, assess them, give them immunoglobulins, give them hepatitis B vaccination. The mother's hepatitis B surface antigen opportunistic vaccination is recommended. Similarly, the paper from NICE guidelines and CDC has got a similar protocol about the importance of screening, the importance of checking viral loads, the importance of using liver function tests. And what is important about this guideline, the the threshold for an ALT should be 3 times from the baseline. And that is when you should be concerned, not slightly elevated, not 1 time, not 2 times, but 3 times. And that is the threshold for interference, for interpretation, for medications and intervention in such patients. So ladies and gentlemen, take home message from my talk today. You should universally screen hepatitis B. I believe since hepatitis C can be eliminated, we should also universally screen for hepatitis C. It's important to offer opportunistic vaccination for hepatitis B. It is not contraindicated in pregnancy, in the prenatal clinic, and the postpartum clinic. If the mother's got hepatitis B surface antigen positive, check her E antigens. If it's positive, her risk of transmission is higher. But one important test, apart from the liver function test, which should be 3-fold increased to be of concern, apart from the viral loads, apart from the ultrasound, check for viral loads at 28 weeks. And if the viral loads are high, tenofovir is recommended. Tenofovir is safe. Tenofovir is efficacious. So with that, ladies and gentlemen, thank you so much for your attention. If you do have any queries, I'll be more than happy to answer them. Kindly reach out to us via our website, www.obstetricmedicine.my. Thank you so much for your attention.